I'm not going to introduce the next presenter. Um, so one of the areas where I think endovascular technology has really had a major impact is in the management of patients with type B aortic dissection. These are my disclosures. So when we look at aortic dissection, there's a reason why it occurs where it occurs in the aorta. They have done some finite element analysis, stress analysis, and there are specific areas of stress that occur along the aorta and the aortic arch. One is at the beginning of the ascending aorta, and the other one is just distal to the left subclavian, and that happens to be where we see most of the aortic dissections. Now, aortic dissections are typically classified by the aortic segment that is involved. That is type A, is in the ascending aorta, and type B in the aorta distal to the left subclavian. There are other classifications, but clinically this is the most useful. It is also classified by the duration from the clinical onset, acute being called within the first 14 days, subacute 14 days to 3 months, and chronic greater than 3 months. I will submit to you that this classification is being challenged in terms of the management of the patient. I think there are clinical factors that are more important than the duration from the clinical onset. One is whether it's complicated or uncomplicated. Basically complicated meaning that it has some of the features that lead to early death after dissection, and we'll talk a little bit about that. So we're going to concentrate on type B aortic dissection, where the aortic tear is distal to the left subclavian with prograde dissection. Medical treatment is associated with about an 11% mortality. Surgical treatment in that acute phase is associated with about a 31% mortality, but I need to caution you because these two groups are not comparable. Usually, surgical treatment is reserved for patients that fail medical therapy. So endovascular technology has changed the paradigm because it is intended to obliterate the proximal tear and then deal with the complications specific either surgical or endovascular treatment. One of the things that is emerging is the timing of this endovascular intervention. When is it best to do it is becoming clear. So one of the biggest factors in a complicated aortic dissection is the concept of malperfusion. And this is a concept that we mostly had for many years in terms of what's causing the malperfusion. And basically what you have is the dissection coming in through, dissecting into the branch, causing arterial thrombosis. It turns out that this only happens in about 20% of the cases, with most of them being what is called dynamic obstruction, where there's intermittent obstruction by the intussuscepting septum into the branch. So what happens is during systole, the septum of the dissection goes and occludes the branch, so there's no flow during systole, there's only flow during diastole. And that's why in the old days, when angiography used to be a big component in the evaluation of these patients, we would put a catheter here, perfuse, inject at 900 pounds per square inch, and everything would be normal, except the patient would not be normal. The patient would be having pain, be in renal failure, and eventually die because we did not understand this dynamic process. Can you go back one, please? Go back one more. So basically, with intravascular ultrasound, you can see exactly what's going on with the septum. During systole, you can see here the superior mesenteric artery. Now you're going to see the celiac. And basically, the only thing that is preventing complete occlusion during systole is the presence of the catheter. If this catheter were not here, this would be occluded during systole. So this is a good demonstration of what happens in a patient that is having dynamic malperfusion. So there were two trials, one by W.L. Gore and the other one by Medtronic, one with the CTAC and the other one with the Valiant device, looking at acute complicated dissection where patients were randomized to either surgical therapy or best medical therapy in patients with acute dissection. And in both instances, they demonstrated that endovascular treatment of patients with acute type B dissection that were complicated. These are patients that either have malperfusion, impending rupture, or rupture. The results were better with an endovascular intervention. So interestingly, the FDA approved the graft for dissection, but it also approved it for all lesions of the descending thoracic aorta. So basically, these two devices were increased in their instructions for use for patients with complicated dissection. So when we're looking at, in terms of who gets an endovascular intervention, where clearly patients with complicated type B dissection, which is about 20% of patients, should be treated with an endovascular graft during the acute phase. And these are patients with either rupture, impending rupture, rapid enlargement, that means in-hospital growth, which means that these patients, when they get admitted, they get the diagnosis, and then 48, 72 hours later should have another CT scan to see if there is growth, and patients with malperfusion, either static or dynamic. So in the short term, outcomes are better with endovascular treatment of complicated type B aortic dissection. Now, what happens to the other 80% of patients? Well, there was a trial called the INSTEAD trial, which was published in 2009, where they took patients that were greater than 2 weeks with type B dissection. These are non-complicated patients considered in the subacute or the chronic phase. What's important is that 597 patients were evaluated, but only 140 were randomized for various reasons. But these 140 patients were very, very carefully followed. They were clinically stable patients that were either from 2 to 52 weeks from the onset of the dissection. So this really includes patients in the chronic phase. They were all anatomically suitable for endovascular repair. It took about 6 weeks from dissection to randomization on average, but from randomization to treatment, it took about another 1.5 to 2 weeks. So if you look at from dissection to treatment, it was somewhere between 6 and 8 weeks that these patients were treated. So these were patients that were clinically stable and anatomically suitable. So I think when one starts developing a selection criteria for endovascular intervention, those are two extremely important factors. The patient needs to be stable and it needs to be anatomically suitable. So they followed these patients and they reported the results at 24 months, and lo and behold, there was no difference between best medical therapy and endovascular intervention. So for the first 2 years, there appears to be no difference in survival in these patients. So this is our second selection criteria. If you have a patient with limited life expectancy, then it makes no difference to do an endovascular intervention or to continue to treat them with best medical therapy. Why is that? Well, if you look at what happens in the first 6 to 8 weeks, there's really no difference between an endovascular and continued medical therapy. And that has to do with the fact that endovascular has some complications. There's a mortality of about 10%, 2% conversion to surgical. Retrograde dissection occurs in about 2% of patients. There's a neurologic complication. So overall, the morbidity of an endovascular intervention in the acute phase is about 20%. So if you look at the results in the first 6 or 8 weeks, there's really no difference. And if you look at the retrograde dissection, this is a feared complication in the acute phase. It tends to happen more when you oversize the endovascular graft. So it's been calculated that for each % of oversizing, the odds ratio increase about 9%. So when you're treating these patients, you want to keep the oversizing to a minimum, usually not more than 10% of the size of the normal undissected aorta. So then they continued to follow these patients, and then they reported the 5-year results, which is the INSTEAD XL, or the extended INSTEAD trial results. And lo and behold, after 24 months, you start to see a divergence with an improvement in survival in patients that were treated during the subacute phase, usually within 6 to 8 weeks, with an endovascular intervention. So once you go beyond 24 months, overall mortality is improved with an endovascular intervention, aortic mortality is improved, and progression is actually seen more in patients with continued medical therapy. So what we're seeing is that there's a difference between the acute mortality and the chronic, or so-called chronic mortality, which is usually after about 2 to 3 weeks, preferably 6 to 8 weeks after the acute event. Complications come down, and there's better remodeling when the endovascular intervention is carried within the first 90 days. And complete obliteration of the false lumen leads to improved survival. False lumen thrombosis occurred much more frequently with early intervention, meaning within the first 6 or 8 weeks. False lumen thrombosis occurred in only about 22% of patients with best medical therapy, in about 90% of patients that were treated with an endovascular intervention. But it is important to underscore the fact that these patients continue to have what they call best medical therapy. And that's important because these patients, once you put the endovascular graft, you're not done with them. These patients need to understand that what you're doing is you're trying to modify the natural history of the disease, but you're not getting them back to normal. So there appears to be a little bit of a sweet spot between 4 to 8 weeks in terms of intervention with an endovascular graft. Importantly, there are about 4% of patients that will have spontaneous resolution of their dissection, and that's another reason why you don't want to treat everybody that is clinically stable and suitable for endovascular intervention. There's a few parameters that emerged from the INSTEAD trial. One of them is if the initial proximal descending aorta, the false lumen diameter, is greater than 22 millimeters, you can see that there is a greater incidence of enlargement of the aorta, whereas patients that were below 22 millimeters in the false lumen tended to have a much less increase in the size of the aorta. So this is another criteria that one can use to determine patients that are better suitable for relatively early intervention. If you look at the diameter of the entry tear, if it was greater than 10 millimeters, 100% of the ruptures occurred with an average of 14 millimeters of the entry tear, and 100% of the crossovers to endovascular from best medical therapy had about a 13 millimeter diameter of the entry tear, which means that if you have diameters of the entry tear greater than 10 millimeters, these are patients that are better treated with a more aggressive approach with an endovascular graft. Now, best medical therapy equals blood pressure control. And if you look at the INSTEAD trial, they had absolutely excellent blood pressure control. The average, their mean blood pressure in the best medical therapy and in the best medical therapy with endovascular was in the order of less than 100. So these were patients that were very aggressively treated with medical therapy, which means that if you have poor blood pressure control, you should probably proceed with treatment so that you can accomplish better pressure control. So here's a typical patient with an acute dissection and enlargement, and you can see that the left renal artery is actually coming off of the false lumen and probably less well perfused, which indicates why the patient has poor blood pressure control. So these patients, we close the proximal fenestration, and then we look at the renal artery. You can see that we've gone from the true lumen to the false lumen with a covered stent. And now what we're doing is we're perfusing the left renal artery through the true lumen with a covered stent. So basically, cover the proximal tear and then redirect flow from the true lumen into the artery perfused by the false lumen. Here's a more complicated patient. This is a patient that had an endovascular AAA repair, presents with right lower extremity pain, postprandial pain, and renal insufficiency. And basically what happened is that the dissection thrombosed the infrarenal endovascular repair. And this is just to underscore that all of these patients are complicated. They are all very complex cases, and they require sort of an individual approach. So what we ended up doing in this patient, and this is something that we've had very good results with and we continue to use in very selected patients, is we debranched the patient to take care of the malperfusion and then placed a proximal endograft. You can see what happened in between here. The true lumen remains very, very small, and the patient developed an enlargement of the aneurysm in this area here. So we basically completed the repair several weeks later by placing another endograft between the proximal repair and our infrarenal graft, seeing the back perfusion. And this patient has done extremely well, was done in 3 stages, and has an aorta that's covered from the left subclavian all the way to the bifurcation where there is a surgical graft. You can see the surgical graft which was used to treat her initial problem. So what we learned from this type of approach is that staging these repairs actually decreases the risk of paraplegia. So here's another patient. Could you click that video, please? That presents with a type B dissection and proximal descending thoracic aneurysm, renal malperfusion, and left lower extremity claudication. So what we're doing in this particular case is we're fenestrating the infrarenal aorta. So we're creating a single lumen. Then we go ahead and replace it. You can see the dissected infrarenal aorta down here. So we're going to place a bifurcated graft. And from there, we're going to go ahead and take care of the malperfusion with retrograde grafts. We're doing the same thing with the iliac. So we're doing an aortobiliac reconstruction. You can see this reconstruction here, and the retrograde grafts. What that allows us to do is then treat the aortic dissection by basically placing the endograft instead of in the true lumen, in the false lumen, because we're going from true lumen here down to our surgical graft down here. So basically the false lumen is now perfusing this bottom part. Now that's kind of a odd way to approach this. You can see here that we have our intravascular ultrasound in the false lumen with the true lumen being out here. The advantage of that is that you now have the device going through the larger of the 2 lumens and actually is supporting the weaker of the 2 lumens. So we think this is something to be considered. This is a different patient where we place the graft from a previous surgical graft all the way down to another surgical graft down here. Basically it allows full expansion of the endograft as opposed to the patient that you saw previously. It improves distal perfusion. It actually may preserve some of the intercostals that are coming from the false lumen. It excludes the weaker lumen, and I think IVUS is absolutely essential for the management of these patients. So in summary, the initial management of a type B aortic dissection is medical, beta blockers and blood pressure control. In complicated cases, endovascular intervention is the treatment of choice if you have suitable anatomy. And I believe elective endovascular repair within 6 to 8 weeks in the rest of the patients, if they have a life expectancy greater than 2 years, have suitable anatomy, have poor blood pressure control, greater than 10 millimeter tear, or greater than 2 centimeter proximal false lumen, early aortic expansion, intermittent pain, or if it is the patient's preference. And I appreciate your attention and will be happy to answer some questions during the discussion period. Thank you.